right, so tonight's program is MS NeuroTV, and it is a virtual online program. And of course, this is, you see that guy there? He's a younger version of me. He's got a little bit more black hair than me. My name is Stuart Schlossman. I'm president and founder of MS Views and News. Remember, everybody, I too am an MS patient, and the name of the organization is MS Views and News. We are sponsored by, for tonight's program, was supported by Bristol-Myers Squibb and Biogen. All right, and tonight we have Dr. Harvey Samowitz. He's a urologist, and Dr. Samowitz is a medical doctor. He's a fellow of the American College of Surgeons, fellowship trained in female pelvic medicine and reconstructive surgery. He completed fellowship at Northern California Continence Clinic in urogynecology, female urology, voiding dysfunction, and many other things. So ever since his fellowship in voiding dysfunction, he's had an interest in neurogenic bladder. He's been involved in the clinical research that got Botox FDA approved for the bladder, and he continues to participate in studies and clinical research. So first, Dr. Samowitz is going to speak for about 15 to 20 minutes, and then we are going to do the question and answer period. Okay, so there you go, Doc. Take it away. You're up.
Thank you, Stu, and I want to thank you again for putting these talks together. I think it's a real service to the MS community. So, and I appreciate all of you for signing in. I'm going to talk a few minutes about what I know of bladder dysfunction and avoiding dysfunction with the MS population, but I also want to leave enough time for questions and answers, because I think that's usually the fun part of these talks, is to hear what's really on people's minds. And so we'll have plenty of time for that, I promise. So the issues of avoiding dysfunction in the MS population is very similar, of course, to the general population, in the respect that overactive bladder, urinary frequency, urgency, and urinary incontinence are very, very prevalent. It's a very common problem in our population. The MS patient has some unique aspects to their problem, but for the most part, overactive bladder affects 48 million Americans, and most of these patients tend to be female. It gets worse as they get older, and we're not quite sure why that's happening in the general population, but when we have an MS patient, it may start earlier and may be more severe to have that urinary frequency and urgency. Now, how do you define urinary frequency? Typically, we say that patients that are urinating more than every 3 hours is having abnormal urinary frequency. You shouldn't be urinating more than 7 times a day and no more than 2 times at night. The nighttime frequency is referred to as nocturia, and that term is important because it's got some unique aspects to it. Nocturia shouldn't be more than 2 times per night because it interferes with your sleep pattern if you're getting up more than twice and you wake up you wake up not rested. So it's very important to address the nighttime frequency or nocturia. And it's also easier for the urologist to ask, how many times do you get up at night? Because if I ask you, are you urinating more than 7 times a day, it's going to be hard for you to really think about it and record that. So when we talk about urgency is that desire, that overwhelming desire to need to urinate. And that's a tougher problem. Some patients will have urgency even after urinating. They've emptied their bladder and they still have that strong urge to urinate, and it's sometimes a difficult problem in and of itself. So when we talk about some of these symptoms of urinary frequency and urgency, nocturia, we will try to do a workup that includes a good history and then a check of the patient's residual, making sure that they're emptying their bladder adequately when they leave the bathroom. Every once in a while, we come across a patient who thinks that they're emptying their bladder well, but when we do an ultrasound and check to see how much is left behind, it's sometimes deceiving and remarkable how much they leave behind, and therefore they're leaving the bathroom already partially full. So it doesn't take them long to have to go back to the bathroom because they're already leaving the bathroom and there's a lot left behind. And they can't tell that. So we will check their residual. We'll also make sure the patient doesn't have any signs of a urinary infection. Sometimes that will cause frequency and urgency because the infection is irritating to the bladder. And the bladder is a somewhat stupid organ. It only knows two things, full and empty. So any kind of stimulation to the bladder will make you feel like you have to go even when you are already empty. There's other things that can cause stimulation of the bladder, and those can run from certain foods that are irritating, particularly caffeinated beverages, alcohol, acidic or spicy foods, aspartame, pickled foods. Some of these are irritants to the bladder and trick the bladder into thinking that it's full and that you have to go when you really don't. So when we talk about the workup, we sometimes will do a cystoscopy. In complicated cases, we'll do something called urodynamics. Now, urodynamics is where we try to assess the bladder function in the office setting so that we're duplicating what is happening to the patient by filling their bladder slowly with water while they're hooked up to the computer. And this way, we're measuring certain activity of the muscles, the pressures, and what the patient's feeling as we slowly fill them with water. And then at the same time, after they've filled during the filling phase, then we check them again during the emptying phase. And we have the patient urinate in a commode while they're still hooked up to the computer so we can see how well their bladder contracts and if their pelvic floor is relaxing appropriately. Since we're on the subject, I think I probably will mention what's sort of unique to the MS patient. We sometimes will have the patient, sometimes the MS patient will have something called dyssynergia. So to understand dyssynergia, you have to understand there are two phases to the bladder. The phase where the bladder relaxes to store urine, and then the pelvic floor and the urinary sphincter contract the whole urine in. Then during the emptying phase, the bladder has to contract to push the urine out, and the pelvic floor and urethral sphincter have to relax to let the urine out. What happens sometimes in the MS patients is a lack of coordination between the bladder and the sphincter, so that the bladder starts to contract, thinking it's full, and the pelvic floor and the sphincter haven't relaxed, and they're holding the urine in while the bladder is pushing against this closed outlet. And that causes sometimes damage to the bladder, and in severe cases, even to the kidneys, where the urine backs up. So that's sort of unique to the MS patients. It's called dyssynergia. But getting back to sort of the routine patient who has the early onset of urinary frequency and nocturia and urgency, we usually will start treatment with the simplest method, which is behavioral modification. We'll ask the patient to try to do Kegel exercises. Many of the women are familiar with that. That's where you tighten your pelvic floor muscles, and that stops the urge. There's a reflex that turns the bladder off. So you could do those Kegels, and that will sometimes stop that urge. There's also what we call timed voiding. There, you don't depend on the urge because you don't get enough warning time to get to the bathroom. So you look at the clock, and about every 3 hours, you go to the bathroom and empty in anticipation of having that strong urge and doing the void before you have an accident or before you have that strong urge. There's also fluid reduction. Now, of course, it's important to be well hydrated. It's important for your kidneys and your overall health. But we tell patients if they're getting up too much at night, which is really their biggest concern, to stop drinking for about 2 to 4 hours before they go to bed. The fluid that you drink after dinner is going to be turned into urine while you're sleeping. So it's sometimes not a bad idea to try to drink most of your fluids during the day when it's easy enough to get to the bathroom rather than waiting till before you go to bed. There are many medications that are out there for the urinary frequency and urgency. There's actually 4 generations. The first generation, I'm sure many of you are familiar, called oxybutynin or ditropan. The second generation, Detrol and Sanctura. The third generation, Vesicare, Enablex, and I'm blanking on the third one. And then the fourth generation is Myrbetriq. And Myrbetriq is the one that's sort of unique. It's been out, it's the most recent one, and it's the one that has the least amount of side effects. It also has a different mechanism of action than the other ones. And I like it a lot because it doesn't have the side effects. It's safe in the elderly population, and it is effective, but it's sometimes not covered by insurance and can be expensive. When the medications are not effective, there are other options, or if the patient doesn't want to take medications, there's things like Botox. We inject Botox into the bladder, and that will calm the bladder down. It partially paralyzes the bladder. It has to be done through a cystoscope. It lasts about 6 months, but it is effective, and I use a fair amount of Botox in my MS population. It's not a bad procedure. It takes me about 5 minutes, and it can be done in the office. Some patients prefer to do it with anesthesia, but over time, a lot of them just will do well with it in the office. There's something called posterior tibial nerve stimulation. And that's a procedure that we do in the office. It's a little time consuming, and it may not be the best thing for the MS patient, but basically the patient comes into the office and we put an acupuncture needle. Let's see if I can show you. We put like an acupuncture needle by their ankle, and there's a nerve that runs up to the bladder. The posterior tibial nerve runs up towards the bladder, and it calms the bladder down. The problem is in MS patients, obviously, the nerves are not working all that well. They don't necessarily handle electrical stimulation as well as normal nerves, and it is time consuming. It has to be done weekly for 30 minutes every week for 12 weeks. So not everybody wants to sit in the office for 30 minutes to get a nerve stimulation. And then the last option really for severe intractable urinary frequency and urgency is sacral nerve stimulation. The original company that came out with this is Medtronic, and it was called Interstim. And I started doing Interstim about 20 some odd years ago when it first came out. And for many years, that's all that was available was Medtronic Interstim, and they didn't update their technology. And it was only about a year or two ago, another company came along and used their technology and updated it and improved it. And it's called Axonics. Let's see. Axonics does the sacral nerve stimulation that the Interstim does, but they built a better mousetrap. They made it so that patients can still have MRI. The patients don't have to have the battery changed every 5 years. It's a rechargeable battery, and it's very small, and they just updated the technology and made it more user-friendly. So I've been doing a lot of the axonic sacral nerve stimulation because once it's in, the patient doesn't have to do anything. They don't have to think about it. It's sort of like a pacemaker for the bladder, and it's a very useful technology because it's for the patients where nothing else is working. Other issues that will affect the MS population is incontinence. And urinary incontinence can be basically of three types. There's the urge incontinence, where the bladder starts to contract without the patient's permission, and the urine just comes out. The other type of incontinence that's common is stress incontinence. Stress incontinence is not the stress of a bad day. It's where the sphincter, the valve, is not holding tight, and through pressure on the abdomen, the patient coughs, sneezes, laughs, lifts, strains, bears down, the sphincter falls down, and as it falls down, it lets go. It opens up. So we have to do something like a sling, which is a simple tape that goes through the vagina, and it just holds the urethra up so it shouldn't fall down. It's not squeezing anything. It's not causing any pressure on anything. It just sits there and prevents the urethra from dropping and opening up and letting the urine out. The last type of incontinence is more significant in the MS population, and that's where you have intrinsic sphincter deficiency, where the patient may have been wearing a catheter for a long enough time, where the sphincter, the valve that's supposed to keep them dry, has been destroyed or disrupted from chronic pressure. And now, instead of having a muscle that can hold the urine in, let's see this way here, instead of a muscle that can hold the urine in, it's just open. It's just sitting there, and it's open, and the urine just pours out. And that's a tough problem, where we do various things to try to stop it. We sometimes will inject a bulking agent, sort of like the same materials that the plastic surgeons use in the face, to bulk up the sphincter, to tighten it up like a washer and a leaky faucet. Or we can use a sling, like I just mentioned, a piece of tape to pull it up tight. And finally, in severe cases, we sometimes end up having to close the urethra when it's that badly damaged and there's no other choice. And then finally, the other real problem in MS patients is a neurogenic bladder. And what neurogenic bladder means is a bladder that does not contract, it does not empty. The patient goes into non-obstructive urinary retention. And neurogenic bladder is a tough problem because there aren't a lot of choices for managing this. We don't have a significant amount of options. So one of the options is when a patient goes into urinary retention and can't empty their bladder, and it's not due to obstruction. We're not talking about the male patient who has an enlarged prostate, and female patients don't usually get obstruction. So the patient that goes into retention and it's not obstructive, the first step sometimes is self-catheterization. And self-urinary catheterization, self-intermittent catheterization, is where the patient learns how to take a small catheter. It's not like a Foley, it's smaller and simpler. They slide it in the urinary tract, they empty the bladder, and they take it out and toss it away. And it actually sounds a lot tougher and more invasive than it really is. It really becomes second nature to these patients. It's like brushing their teeth. It's not much more complicated. And I have some patients that really have had an enormous amount of freedom and independence by being able to self-catheterize and go about their day. A typical patient will catheterize about 4 times a day. When they first wake up in the morning, twice in the middle of the day, and once before they go to bed. And they can usually stay dry throughout the day. They don't have to wake up to urinate, and it's not a bad option for a lot of patients. And it's simple and has been around since the Egyptians, since they took papyrus reeds from the Nile. So it is it's still one of the better alternatives in the appropriate patient. But some MS patients obviously don't have the manual dexterity to be able to catheterize themselves. And so we have to then rely on a Foley catheter, like a urethral Foley catheter. Now, urethral Foley catheter is a chronic indwelling catheter that the patients eventually can get problems. And I mentioned one before where the sphincter gets damaged and is no longer able to hold urine, and that's not a great thing. Foley catheters are really not meant to stay in chronically. They're really meant to be sort of a short-term solution. But in some cases where we don't have other choice. The last resort, the other resort is the suprapubic tube, where we don't have a catheter in the urethra, in the vagina or in the urinary tract, but it's a simple process of placing the tube directly through the skin and into the bladder, and it comes out below the belly button. And that catheter is still connected to a bag, like you would with a urethral Foley catheter, but it's much easier to take care of, much easier to change. The patient who is in a wheelchair doesn't even have to get out of the wheelchair to change the catheter. And it's easier to keep clean. There's less infections, and it's more comfortable for most patients. And it's a simple procedure to place that, which is local sometimes. And we just pop it into the bladder. What's also interesting is that the device I was talking about a little while ago, the Axonics and Interstim sacral nerve stimulators, do work for the non-obstructive urinary retention patient. And they can help those patients that are not able to void on their own to spontaneously void, and it does work. Unfortunately, in the MS population, it doesn't really. It may not last as long, and I think there's not a lot of studies on this, but I have a feeling the demyelinated nerves don't carry the electrical stimulation as well as in a regular myelinated nerve. So, but it is an option for patients who have non-obstructive urinary retention. We can do the sacral nerve stimulation implant, and it's an outpatient procedure. It's done under local, and it's relatively simple and available for those patients who need it. So I'm going to cut myself off there and leave myself some time here for questions and answers.
Fantastic. Thank you very much for that. And we have to give everybody, I need you all to like clap hands. You're at home, but I can hear you. No, I really can't. All right. So we want to thank Dr. Samowitz for giving that presentation. And again, for anybody who has questions, please type them in at the top of the screen. I will be going through the entire list that I do have in front of me. It's going to be longer than a half hour, right? It could be an hour of questions here, but we will try to get to all of them. So the first one, person is writing, I do not know who some of these people are. For those that I do, I will say their first name. All right, this person is asking, has anyone had the Interstim device implanted in their lower back for urinary frequency? Now, I realize that some of the questions that I'm going to ask you might be things that you might have spoken about, but there may have been people that came on before or after that you were talking.
So yes, Interstim is used for both extremes, for both the overactive bladder, the intractable overactive bladder with urinary frequency and urgency, and on the other end of the extreme, the other end of the spectrum, for the patient with urinary retention. So we do place them in the lower back. It's done under local anesthesia, and yes, that is an option.
Okay, thank you for that. Next question. Can pelvic floor therapy help bladder urgency that's due to multiple sclerosis?
Can what therapy? I'm sorry?
Pelvic floor therapy.
Can pelvic floor
exercise?
Yes, that was what I was talking about with behavioral modification and Kegel exercises. Basically, Kegel exercises are pelvic floor therapy exercises, and they are very useful. They're good in MS patients as well.
Okay, great. Thank you for that. All right, so there's an Elizabeth. I'll go back and forth between those that are online and those that are in front of me. So Elizabeth is asking, have you used tamsulosin I'm sure I'm not saying it right, but tamsulosin. Oh, good. I'm glad. Oh, I should have a MD on my name. All right. All right. Have you used tamsulosin for incomplete voiding in MS patients?
So tamsulosin is Flomax, and it's the number one. There you go. You recognize that. It's the number one medication prescribed by urologists, and for good reason. It's safe and effective, and now it's generic. It's cheap. And we use it in males who have urinary frequency and urgency just to relieve the bladder obstruction and calm the bladder down due to the prostate being enlarged. We do it also in women who may have some urinary retention. It may help. It's anecdotal. I can't say that there's been great success with it. By the way, we also use it in patients who need to pass the kidney stone because it's supposed to relax the urinary tract and allow the stone to come out easier.
Okay, thank you for that. All right, next, how do you determine if neurogenic bladder is a result of aging or MS?
Wow.
Good one.
Yeah, it's a good one. Well, it really doesn't matter the cause, does it? I mean, if they're still having a neurogenic bladder, we're going to treat them the same, whether the cause is due to aging or MS. But, generally speaking, we don't see neurogenic bladder except rarely in older women for no good reason. I got to be honest. It's not clear why, but I have I have a few 90-year-old plus patients whose bladders just became floppy sacks and they just can't push the urine out, and we have a problem getting the urine out of them. But it's not a common problem in the general population, whereas it's much more common in the MS population.
Okay, thank you. All right, next is from someone named Jill online. What is your experience with electrical ankle stimulation?
So electrical ankle stimulation, I think they're referring to what I was calling the posterior tibial nerve stimulation. That's the thing I was showing you where you put a little acupuncture needle by the ankle and it goes up to the bladder. The problem in the MS patients is that their nerves are not able to transmit the electrical energy as well as a normal nerve. It's very time consuming. It's 12 sessions of 30 minutes each for 12 weeks, weekly sessions, but it works okay in the general population, not as well. It's 80% success in the general population. I don't think it's as good in the MS population.
Right. So but not all the MS patients obviously have the same nerve issues. So it's possible then that it could work on somebody with MS and not work on another person with MS, correct?
Correct.
Okay. All right. Next question. I would like, a person is writing, it's not I, but a person is writing, I would like to know about the surgical procedure for bladder issues.
Which surgical procedure they're referring? I'm not sure.
That was the question. Just like it was. So I will skip over that one for now, and maybe we'll find something later on that it can reflect to. I have no clue. We'll see what happens if there's another.
They can add something to that and fill in a little bit more detail, and I can help them out.
All right. So if the person is online right now with us that wrote that question in when he or she registered, maybe you can expand on that and let us know what, if you can repeat the question and include what else it might have been for, okay? And again, everybody that's online, I do see that people are writing in questions, maybe as he's answering questions, but I can't go back and forth like that, all right? So I can only look at the top and then view to the bottom. All right, next, what's the best way to handle constipation with multiple sclerosis?
Great question. It's a great question because a lot of people don't appreciate that the bowel and the bladder live next door to each other and they have a direct effect on each other. So when the patient is constipated and the bowel isn't working right, the bladder may not work right. Patients can go into retention, urinary retention, just from constipation itself. There's reflexes that go on between the two organ systems. So the best way to treat constipation, gosh, I deal with that question every day with all of my patients. I got to tell you, there's no great perfect solution. Now, what you can do, this is what I tell a lot of my patients. I say, go to the drugstore and ask the pharmacist, because that pharmacist has a lot of knowledge, and he's also the one that is watching what people are buying off the shelves. And there's an entire aisle dedicated to constipation in every pharmacy. And he can tell you what's working for the patients that come in and what doesn't. So I often refer them to the pharmacist to help us to figure out how to treat constipation.
Okay, thank you. Next, Shelley writes, have you ever heard of Latchkey Incontinence? The second I out the key, the lock, there it goes. I don't understand that.
Oh, I know what she's talking about.
I'm reading what's written.
No, I understand what she's talking about, that there's triggers that will stimulate the bladder. So you're trying to get inside the house and you got the key in the door and you're trying to open the door and it's starting to come out already. Or you hear the sound of running water, or you're washing the dishes, or you're walking past the bathroom, or any of these triggers. There's a strong mind-body connection between the bladder and the brain. And we know this, but is there anything to do especially for it? No. I mean, it's a trigger.
So I got one to make everybody laugh about that. I could be on the highway, which I do every week, going back and forth to the studio. And if I pass a rest stop without stopping, I feel like I have to go. So I have to stop the next one. All right. That's very interesting. That's very funny too. All right. Amy is writing, what's the best way to handle chronic diarrhea and urinary frequency? Does that have anything to do with what you just spoke about?
Well, if she's having chronic diarrhea, that's sort of unique. That could be irritable bowel syndrome. And patients that are having irritable bowel syndrome, overactive bladder is sort of the other side of the coin of irritable bowel syndrome. So I don't know if she should talk to a gastroenterologist and see what to do about that. Now, if the patient is having fecal incontinence, if they're leaking feces, that's a different problem, and that's a serious problem. That's actually worse than the patient that has urinary incontinence. And for the fecal incontinence, what they do is we would do a interstim. It's one of the only really good treatments for fecal incontinence is the sacral nerve stimulation, axonics or interstim. Will be more effective at fecal incontinence than sometimes urinary incontinence.
Okay. All right. Going back to what's written down here, bladder training. Do you have are there safe devices to use at home for bladder training?
Yeah, as long as it's not nuclear powered, I guess. I mean, when you talk about a device for bladder training, I'm not sure exactly what device there is. Most of the bladder training is based on you doing the correct muscle exercises, and you don't need any real device for that. What you really need is good training to understand which muscles we're talking about. These are not intuitive muscles. These are not muscles that you're used to knowing where they are and that you tighten them consciously. So there are some devices out there. For example, there's one where women will put some weights in the vagina, and with increasing size and weight, they will hold it in and try to maintain it. Whether or not that's necessary, I don't think so. What we do in our office is we train patients to do these exercises by putting a manometer either in the rectum or in the vagina and just showing them or electrical activity, just EKG pads on their bottom, and showing them a monitor and saying, okay, we want to make that green line go up. So use whatever muscles you need to identify which muscles we're talking about. And when they see that biofeedback, they learn which muscles they have to practice on their own when they go home.
Okay, thank you. All right. Paula is writing something I really don't understand, but hopefully you will. I use self-cath TID and yearly. I get Botox injections yearly. Is there anything else helpful?
So what the patient, I think, is referring to is she's doing self-intermittent catheterization, like we talked about, 3 times a day. And in order to stay dry in between those 3 times a day, she's getting Botox to keep her bladder calm so it'll store better in between. That's not a bad combination. I mean, those patients do quite well with the Botox, keeping their bladder calm, self-intermittent catheterization. It's not a bad option at all. And then the advantage of Botox is they're not taking pills that are causing dry mouth and constipation, and there's medicine that's going through the entire body. Botox is a target organ medication. It's put in the target organ.
Okay, thank you. All right, next, it's from Jill. How do you measure stress incontinence and decide a sling would be beneficial?
So that's part of the art of medicine. That's where we evaluate the patient. Personally, I do certain things that help me to understand what they have in terms of if they have stress incontinence. First of all, history is key. You ask the patient, do you leak with coughing, sneezing, laughing, lifting, straining, bearing down, jumping, or running? You ask them how many pads a day they use. I often will do a cystoscopy, which takes me about 60 seconds. It's cold, it's wet, it's uncomfortable, but it should not be painful. And I look at their sphincter muscle. I look at the muscle, and does it look like that, or does it look like that? And if they have a sphincter that's sort of open, they're more likely to have stress incontinence. I also get a chance to fill their bladder with water during the cystoscopy, so I get an idea of what their bladder capacity is like. And then I ask them to cough while I'm watching the urethra, and I'll look to see if any of the water that I put in will drop out as they cough or push down or bear down.
Okay, thank you. We have a whole bunch of Botox questions coming up, excuse me. What are the pros and cons of Botox and sacral neuromodulator?
Well, there are 2 different techniques. The Botox, we inject into the bladder, and it partially paralyzes the bladder for about 6 months. And the sacral nerve stimulation works more with the nerves to get them to work properly, to either store urine better or to get the bladder to contract better when it's time to void. So they're really 2 different modalities.
Okay. Next, will you speak about Botox treatment for bladder issues? Did you already do that?
I think I did. As you mentioned, I was involved in the studies for Botox going back about 20 years. And the studies that we were involved with are the ones that got it FDA approved. So I've been doing Botox a long time. When we were doing the studies, we had to do it in the office. We had to time ourselves. And it typically took us less than 5 minutes. It's not always the most comfortable procedure, but it does work in the majority of patients. It lasts about 6 months, and then we have to do it again. The good news is patients don't build a resistance to it. It seems to continue to work. And a lot of my MS patients need it so that they don't have incontinence or sometimes even bladder spasms. It helps prevent the bladder spasms for 6 months. Again, I like it because it's a target organ therapy. We're putting the medication in the target organ, so the rest of the body isn't having to deal with medication.
Okay, thank you. All right, person is writing, I get 200 units of Botox in my bladder every 3 months. I still leak, especially when I stand up after sitting for a while. I also leak quite a lot at night. I now wear the most absorbent Tena pull-on at night. In addition to the Botox, would Mirabitric help me? Mirabitric? I don't know, I'm not saying it right.
That's this one here. That's this one.
I'll trust you on that.
So they actually have a great commercial. I don't know if you've ever seen the Mirabitric commercial where there's a teacher teaching a class, a band class, and a little cartoon bladder is trying to drag her into the bathroom. There's another one where there's a female attorney who's giving a presentation, and a little cartoon bladder is trying to drag her into the bathroom. So I think that's a very clever advertisement. Anyway, It sounds like, first of all, Botox we can push to higher than 200 units. In a lot of the neurogenic bladder patients or MS patients that need it, I'll go to 300 units. It should last 6 months. Doing it every 3 months is surprising. And yes, you can add various other therapies to the Botox, whether it's Myrbetriq or oxybutynin, whatever medication there is, can augment because they work differently. There's different mechanisms of action. Unfortunately, in some cases, the bladder starts to shrink down, gets really spastic and small, and nothing really works well. And you end up with a small contracted bladder. And that's a possibility. Okay.
Are there any bad side effects to it? To the Myrbetriq, whatever you call this. How about right. The generic name, Mirabergeron?
Yeah, good for you. Good. It's a terribly named product. It's such a shame. First of all, they're missing a U after the Q at the end. I thought a U has to follow every Q.
A QUE or something. I don't know.
But it's a good medication. I'm sorry, what was the question? I got sidetracked there. What was?
Oh, good. So it's a good thing I didn't throw it out yet. All right. So how effective is it? Is it safe? And are there any side effects?
Good. So yes, it is safe. I was involved in some of the research studies for Myrbetriq, and we were testing the elderly population. Some of these medications can cause some cognitive effects in the elderly population. Myrbetriq didn't show any of those effects, so it's very good for that. It's not as drying as the other medicines. It doesn't cause as much dry mouth or constipation, which is the number 1 and 2 most significant complaints for things like oxybutynin. The one side effect it can have is pretty minimal. It can raise the blood pressure a couple points. Not significantly, I found. Only a few patients really had to stop it on account of raising their blood pressure. But theoretically, it can raise the blood pressure a little bit. Now, in the United States, we only use the 25 milligram and the 50 milligram doses. In Europe, they'll go up to 100 milligrams. But they were concerned about the blood pressure effects.
Okay, thank you. For cost, is it like a one price thing for the Myrbetriq, or can you get it at different places for different costs? Is there a way that a person can get it for less than what like CVS or Walgreens pharmacies may have it for?
So let me just say, I am totally disgusted with the pharmaceutical industry and what they charge patients and how the whole system works. So let me just tell you what I try to do with my patients. First of all, I pass out a lot of GoodRx cards. The yellow cards use GoodRx. Now, a medication like Myrbetriq may not be one of the ones covered by GoodRx, but certainly if you go to certain pharmacies, you'll find there's a big price difference. CVS and Walgreens are the most expensive by far, sometimes by hundreds of dollars. So the best pharmacies I find for using the lower cost medication is Winn-Dixie Pharmacy, Publix Pharmacy, Costco Pharmacy. Those are the best. And then in between is sort of Walmart. But CVS and Walgreens are terrible ripoffs. I'm so disgusted.
Okay. One more question about the Myrbetriq. Can men and women both use this, or is it more for one sex than the other?
No, both men and women have bladders.
Thank you. All right. Going slightly different. Let's see. Person is writing, can you choose Botox injections or a sacral? Would you choose Botox injections or a sacral implant?
Would I choose for myself, or would I choose that for my patient?
I would say for your patients.
Okay, because it's very dependent. It's very individualized. I mean, we go through a long discussion to see what's appropriate and what's best for the patient. Now, I personally will probably go with Botox first because it's simple, it's easy, you don't burn any bridges. The sacral nerve stimulation is a process. It's a surgery. It's not a dangerous operation, but the devices are expensive. They're made by the same companies that make the cardiac pacemaker. So it's a pretty costly product, and but we also have to go through steps. The sacral nerve stimulation, interstim or axonics, is usually done in 2 steps. The first step is they have to do a test, and I do the test typically in my office. The patient comes in, they lie face down on a table. I numb up the lower part of their back with a little Novocaine, and then I pass a needle in, and then through the needle, a wire goes through, and then we remove the needle. I bring an X-ray machine into my office, and then we tape everything up. We tape the wire to their back, and they go home for at least a week with that wire taped up to and a stick taped to their side, a little battery taped to their side. And then for the patients that had an overactive bladder, urinary frequency and urgency, they usually will respond within a week. The patients that have urinary retention, however, will take up to 2 weeks or more to see a response. The ones with neurogenic bladder will take longer. So it's a more involved process with the sacral nerve stimulation.
Okay, thank you. All right, next. There are a lot of people writing questions about Botox and Mirabitric and other things, but I also want to, I'm sorry, we just can't get stuck on just those 2 things. I know that you think I'm wrong about that, but there are other things to look at here as well, all right? So let's go off topic a little bit. A person named Barbara is writing, I was on Vesicare for 8 years and then went off it for 70 days. My insurance dropped from the formulary option. At first, no problem, but after 45 days, I started to have urge incontinence. So I have gone back on Vesicare. Now it seems it's more difficult to stand up and to transfer on the toilet. Do overactive bladder medicines affect other nerve? Boy, I got off the thing here. What happened here? I lost the, I got to find this question again. Oh my gosh, right in the middle of things and my screen went poof. Hold on.
Okay. It sounds like they're asking, does the Vesicare affect their ability to transfer? And I would not think so. It's an anticholinergic. It can affect certain muscles in the body, but mostly the involuntary muscles, not the skeletal muscles.
All right. So actually, she went on to say, do overactive bladder medicines affect other nerve transmissions? For example, could it make standing up more difficult?
No, that's a skeletal muscle. So we're talking about muscles like the bladder and the GI tract muscle that causes your food to peristalse through your body. The tear ducts, the salivary glands. There's muscles that squeeze out the fluid, but they're not voluntary muscles. When you're talking about skeletal muscle, which are voluntary muscle, it shouldn't have an effect.
Okay, thank you. Stephen writes, I have driveway incontinence. Can you discuss the problem? Well, it sounds like my rest stop. Sounds like my rest stop problem.
Yeah, it's a trigger. It's just that they're getting close to the door. They're getting close to the bathroom, and the is starting to act on its own. The way it works is that when you're born, when you're a baby, your bladder is somewhat autonomous. A baby can't control their bladder. It'll squeeze on its own when it decides to. And what happens is the nervous system gets more mature, and the nerves between the brain and the bladder that run through the spinal cord start to inhibit the bladder and control the bladder and keep it quiet so it'll store better. And then what happens is when we get older again, or when there's back injury or there's nerve injury or multiple sclerosis, that inhibition gets lost and the bladder starts to act on its own again, like an infantile bladder.
Okay.
So when you have that release of the inhibition, and that release of inhibition can be a trigger that does it, or it can be other things. When you have that release of inhibition, the bladder starts to squeeze.
Okay, thank you. What bladder complications would suggest that a person may need temporary self-cath?
patients that aren't emptying their bladders well and are starting to get urinary infections or starting to develop hydronephrosis of the kidneys start to swell from the back pressure of the urine, or they're starting to really damage their bladder and there's less hope of their bladder being normal. We don't want the bladder to get too distended. It shouldn't go beyond maybe 400 or 500 cc's. Those patients should be doing self-intermittent catheterization. That's usually our first line of treatment for urinary retention.
Okay, thank you for that. Hey, for everybody that's like, there are a few people writing in saying, can you repeat, can you repeat, can you repeat? I don't know where we were to say what it was, but just know that this program is going to be shown on our YouTube channel. It'll be up in a few days. So so once it goes up, we'll notify you all that it's on the YouTube channel, and you'll be able to watch the entire program again, and pause and go back to however you would like. All right, but there's no way we could back up on things at this point in time. All right, Ronald is asking a question. What can help a man who does not completely empty?
So in a male who is maybe at least middle-aged or up, we can always try Flomax to try to relax some of the bladder outlet from the prostate. And even if the prostate isn't a major factor, it's something that may contribute to the retention. So it's something that can easily be done. And again, there's not a lot of side effects from Flomax or tamsulosin. Then everything else we've talked about pretty much. Okay.
Linda's writing, I can't seem to do Kegel exercise anymore due to not being able to feel the contractions. Is that due to a lack of feeling from demyelination? Are there exercises to get that feeling back?
I don't think so, but I'm going to have to defer to my colleagues in neurology about that. I don't know the answer to that.
True. Okay. So Kristen writes, did you say if you drink alcohol, it may affect the ability to go? You feel like, but no PP comes.
So I think what they're saying is, do you get urgency and you feel like you got to go, and then you get there and nothing happens?
Right.
In some cases, it's the bladder sending a false signal, and that's part of overactive bladder, is these false signals, these urges when there's really nothing there. Okay, I'm sorry, I lost track. I started to wander a little bit, but what was the rest of the question again, please? Could you repeat it again? No, okay. All right, I'm sorry. I think I answered the majority of it there.
Yeah, unfortunately, I clicked delete once you start talking about it, so I can't back up on it. All right.
Sorry.
Sorry, me too. All right, so next one is, and this is interesting, James is bringing up a question which was mentioned, the part of the question was mentioned at a previous program we did. I've heard about desmopressin. What are your thoughts about this?
Okay. So he wants to get into the weeds about nighttime frequency, nocturia. So I touched on it, but I didn't want to go too deep into why, all the multiple reasons people get urinary frequency at night. One of them is that people will pull fluid in the lower extremities, that gravity will pull fluid down towards their legs. And then when they finally lie down at night and put their legs up, that fluid is mobilized and shift back into the body and made into urine. So that's one reason for nighttime frequency or nocturia. Another is what he's referring to as desmopressin or DDAVP, which is a hormone that's produced by the pituitary that suppresses the production of urine. And so in patients that are literally making more urine at night, and there are patients that do that for various reasons, that we give them a pill called DDAVP or desmopressin or a nasal spray, and that slows up the production of urine. Now, that can be a little risky because those patients are now retaining fluid, predominantly water, and they can somewhat dilute their bloodstream. And if their sodium gets too low, they can actually have a seizure. So we have to be very careful about who we use this with. Now, we've been using this medication for years in children who wet their beds. And those patients, it's not such a big deal because in children, they're so elastic, they're so adaptable that their sodium doesn't drop very easily. But in an elderly patient who is getting up too much at night and wants to use DDAVP or desmopressin, we got to be careful we're not letting their sodium get so low that they're going to have a seizure.
So we've heard that people are using this for air travel. So they could get from, well, the person that mentioned it is in Los Angeles. And in order for him to get to New York without having to get up from his seat, he uses this so he could make the flight across the U.S. and not have an issue. There are people that are writing with the question for using it for extended travel on auto, bus, train, or airplane. And what are your thoughts about using it at that time of day? Is there anything negative about it?
I don't think there's anything negative about it, but they just need to be cautious about their salt levels, their sodium levels, that they don't let it get too low. It's really sort of cheating. You're using the kidneys to produce less urine because the bladder is not doing its job in storing the urine well. So instead of treating the problem, you're going around it and it's just slowing up production of urine.
Okay. All right. Thank you for that. New question, and it's by two people, a Lawrence and a Jill Elise, and similar questions, so I'm going to put them together. Does medical marijuana and or CBD oil help with bladder issues?
Wow. So I'll tell you that I have patients that have sometimes bladder pain. And I've been talking about this for years, where I'd like to do a research study of putting CBD oil in the bladder and seeing if it relieves their pain. I don't think it's ever been done. And so far, I don't think it's ever been used that way for MS patients either. So I can't really tell you. But I've been interested to do it, but I haven't found any studies on it yet.
Well, you might have to do it on your own. Just get ahead of things, Get ahead.
Okay. Well, get a list of patients that are willing to volunteer their bladders and we'll set something up.
I can do that. All right. All right. Next, back to the original questions. Does diet affect bladder competency?
Well, diet does have an effect on the bladder function. Certainly, obviously, the fluid intake, and then certain foods and drinks are stimulating to the bladder. For caffeinated beverage, for example, you make more urine from caffeine because it's diuretic, but it also stimulates the bladder to want to pee more. So there's also alcohol. Alcohol increases the fluid output, but it also has an irritating effect and stimulates the bladder. So acidic foods, pickled foods, aspartame, the artificial sweetener. Yes, there's a lot of different things that can be. Citrus is known to do it. So there's a lot of things out there, but some people are immune to it. It doesn't matter. The food doesn't make any difference. So it's really, really variable.
Okay, away from the bladder for a minute. A person wants to know, is there any information on anal retention?
Anal retention. That's a psychological term, isn't it? Anal retentive?
I don't know. No. Yeah, well, I'm not getting into that one at all. So
I really don't. Anal retentive would be constipation, I guess.
Maybe. All right, well, you answered that before, so we could go on to something else. All right, so if you don't want to answer it, otherwise tell us again.
How to treat constipation, really?
Is there any information on it? So
there actually is some good information. I happened to see something the other day on the Cleveland Clinic site for MS patients. They address constipation and bowel habits. What I do sometimes is I'll send the patient to a pelvic rehabilitation specialist. And these are our physical therapists who are trained only for the pelvis and treating the pelvic muscles. That means the bladder and the rectum and the anus and the pelvic floor. And they will go through toileting habits with these patients and how to keep themselves regular.
Okay. Next person writes, I wonder if you get Botox on your bladder, if that will stop your sex drive.
No, I don't think it will.
Okay. All right. Next person writes, does an increase in fluid stretch the bladder capacity?
The bladder capacity is a complicated thing. I don't think you can. You could do damage to the bladder if you try to stretch it too much. If you retain urine too long, there's certain occupational hazards for, let's say, teachers and nurses who don't get a chance to urinate during a 12-hour shift or an 8-hour shift. But no, I don't. I'm not sure there's anything else.
Okay. All right. First off, I want to let you know that there are several people that have written great discussion, great topics. Glad that we did it. So thank you, everybody, for saying that. And I just want to let the doctor know before I forget all that. All right. And let me just continue. The next one. Okay. Oh, boy, another hard word for me. Okay. Okay. Katerina writes, okay to stay forever on
Methenamine.
Wow, that's another. Okay. So, okay to stay forever on blank. HIP 1 gram, 2 times per day. Nitrofurantoid. Boy, no wonder nobody could say these things. 100 milligrams after sex were prescribed as prophylactic by urologists to avoid UTIs, even though I have not had any. Only MS urinary incontinence. My neurologist wasn't familiar with this. Is there anything you could say about it?
So what this patient is talking about is methenamine, which is a medication I use a lot. So methenamine is a antiseptic. It's what they used to use before they invented antibiotics. It goes back to the late 1800s. That's how old this medicine is. And methenamine has been around a long time. It's not an antibiotic, therefore you don't get resistance. The problem with antibiotics is that if you use them too much, you develop resistance. Methenamine is more like soap and water, and soap and water is still effective. There's no resistance. So methenamine makes the urine very inhospitable to bacteria. It doesn't cure infection, but it lowers the count significantly so the patient doesn't have any side effects or doesn't have any adverse effects of an infection. But if you go off the medicine, usually the infection will come back. And it's a preventative. I give methenamine twice a day, typically with vitamin C and cranberry pills. And I find that patients don't get infections when we have them on that combination. What the patient was also talking about a little while ago was nitropharantoid, which is macrobid or macrodantin. And that is an antibiotic. It's a good one, but it's a first-line antibiotic, very safe, but we do see resistance. And some patients have the most common reason for a young woman to get urinary tract infection is related to intercourse. And the bacteria that causes the infection is not the patient's partner's bacteria. It's not his bacteria. It's actually her bacteria, her own bacteria that are simply getting pushed up into the bladder and causing an infection. So if these patients are very prone towards recurrent infection every time they have sex, we do give them a tiny little bit of nitropharantoid or macrodantin to avoid the urinary tract infection.
Okay, thank you for that. Person writes, my doctor put me on Premarin cream after menopause. He tells me it will help me fight frequent UTIs. Have you found this to be true?
So there's a whole spiel that I give on how to avoid recurrent UTIs. And one of them is that the woman who is past the menopause, the cells in the vagina are getting thin and dry, and they lack a certain bacteria called lactobacillus. The hormones make this bacteria grow more, makes the cells that line the vagina healthier. They can avoid infections by making a healthier lining of the vagina and changing the bacterial flora. Sometimes probiotics will help too. So yes, there are things that can be done for the vagina that will help prevent urinary tract infection.
Okay, thank you. All right. Back to guys. All right. Michael writes, for males, do you recommend a Urolift for urinary retention?
So Urolift is one of these new techniques that came out for enlarged prostate. It hasn't been out that long. I've done quite a large number of them. I've had kind of mixed results. The idea is that you're going in with a scope and you're sending a sort of a staple to pinch the prostate open. And you pinch it open at like 2 o'clock and you pinch it open at about 10 o'clock. And you pinch it open again at 5 o'clock and again at 7 o'clock. And you're putting in these staples that hold the bladder outlet open. And it's okay. It's not a great option for a patient that's in retention. If a patient is in urinary retention, usually their problem is pretty severe. And a patient that goes into retention has an 80% chance of going back into retention. So we don't really expect Urolift to have as strong an effect on the retention as, let's say, the conventional transurethral resection of the prostate, TURP, which has been around for about 70 years. That is going to probably be a better procedure to open a patient up so that they can urinate again.
Okay, thank you for that. Next, Debbie writes, do you like the stem implantation device versus the Botox? Back to Botox.
So yeah, this is a question I think I answered before, where I think we tailor it to the patient, but I tend to do the Botox first because it's reversible, it's not a big deal, and the patients, a certain percentage of patients will like that and not go on to the sacral nerve stimulation. So I do the Botox typically first, but if the patient doesn't want it, we'll go straight to sacral nerve stimulation.
Okay, thank you. Next, we have, let's try to get away from Botox again for a minute. Kristen, we're going to go back to PP here again. If I self-cath for retention, but can still pee on my own if I need to, is it bad to just cath without peeing first? Will I lose the ability to spontaneously go eventually by doing that?
No, you will not lose the ability to spontaneously go. Self-intermittent catheterization has been around for literally thousands of years, and it's still probably one of the better choices for a patient that's in retention. There's not a lot you could do wrong with self-intermittent catheterization. Patients learn how to place the catheter without hurting themselves. And there's really very little downside. As long as you're maintaining reasonably clean technique and avoiding infection, I can't think of much downside to it.
Okay, thank you. So there's a Reza writes, or Reza, I don't know how to pronounce the name. I developed kidney stones on the top of my bladder. I developed kidney stones on the top of bladder issues, and finally, my kidney is inflamed and infected. Any thoughts or other care I would seek? Thanks.
So there are many reasons why patients can develop kidney stones, and one of them can be infection. And infection can cause stone, and stone can cause infection, and you could get this vicious cycle where you got to get rid of the stone to prevent the infections, because the bacteria that are responsible for the stone will build more stone, and it can be necessary to get rid of the stone to stop this vicious cycle. And urinary infections irritate the bladder and make the bladder want to go more.
Okay, so what you just discussed, is that more common in people with MS than not MS, or how does that work?
It's probably it's not very common altogether, but it might be. It's probably not that common in MS patients. they can make kidney stones as much as the general population, but I haven't seen more stones in the MS population, I don't think.
Okay, thank you. All right, we're going to do this for another 15 minutes, and then I already see that the doctor is slowing down here, and he's losing his voice, it sounds like, so I have no idea. All right.
I'm good.
All right. So Eric writes, I and one other person had allergic reactions to macrodantin, and that he said is very safe. I had hives for entire month. The other person was hospitalized and could not breathe. My itching felt major to me, and also etc. Major problems for this medication, and that's all I can see. So is there anything else that you can add to about that, or?
Well, everybody's different. Some people can have an allergy and nobody else has it, or no one else they know has it. Macrodantin or nitropharantoid is rare to have an allergic reaction, but it can happen to any medicine. And there's different degrees of allergies, and some can have it severe, some can have it mild. It just depends.
Okay, thank you. MJ writes, if one has difficulty using the Foley catheter, would the PureWick female catheter work just as well?
Great question. Okay.
It can only be used for a woman, though, right?
Right. You're familiar with it. Okay.
Oh, I'm not, but female.
First of all, the PureWick, it's something that I learned about when I went to visit a friend of mine in the hospital. I'd never heard of it, so I went to visit my friend, and she said, this is the greatest thing in the world. Basically what it is, it's a sort of a sponge that's shaped like a banana, and it's put down inside the perineum by the vagina. And rather than having a tube inside the bladder draining the urine, it sits there that if they start to pee and they leak urine or they go, it sucks it up so quickly they don't get wet. And it's just a sponge with a suction tube that goes to the wall suction, and it just pulls the urine away from them. And it's a very clever little simple device. I've actually ordered it for a couple of my patients because it's now covered by their insurance. And it's just really simple. Some patients can't have an indwelling catheter for one reason or another, or it's not good for them to have a chronic indwelling catheter. But because of mobility issues, they have functional incontinence that they can't get up to the commode or to the toilet. So once they're in the chair, they're stuck. And therefore, we don't want them to get skin rashes or skin decubiti. So this PureWick is a simple solution. I wish I had thought of it.
Thank you. All right, and next is from a guy who doesn't want his name mentioned, and I don't even know if you're the right doctor for this, but he claims that he has inability to perform sexually because of lack of sensation in his penis. And is there anything that you can tell him for that? Is that for you?
Yeah, I mean, decreased sensation is probably, I would expect, connected to his MS, and but I don't have anything that's going to increase that sensation. Quite frankly, there's just it's a systemic problem. It's not just specific to the penis.
Meaning what? That it's systemic.
That it's related to the MS and how it affects nerves, I imagine.
Okay. Okay. All right. There's a person, I don't remember where the person was, but they're asking where you're located. So can you tell them, please?
Certainly. So I'm in the process of actually moving very slightly. I have two offices. I'm part of a large group right now. I've been part of this large group for 25 years. I recently decided I want a smaller, more personalized type of practice. And so I am going to be moving from my Memorial West Pembroke Pines office, Memorial West Hospital Pembroke Pines office, from 603 North Flamingo to the other wing, which is 601 North Flamingo, one flight up.
So a lot of these people aren't even in Florida, so we should let them know that you're in South Florida.
I'm in South Florida.
There you go. Okay. And if you really want to find him, you could always contact me as well, or you could just Google it. All right. He's definitely there. All right. Pamela's writing, semi-related question, orgasm and incontinence. I void. I am positive my bladder is empty. I get excited, but do not reach orgasm, but I do urinate. How can I stop the latter and reach the former?
This is a tough problem. We'll probably have her use some medication like oxybutynin prior to intercourse to try to make sure her bladder doesn't contract involuntarily during excitement or climax. It's a tough problem. In men who have had radical prostatectomy, who have undergone surgery for prostate cancer, they will sometimes leak during orgasm. And it's not an easy problem for us to manage. We're still working on it.
Okay, thank you for that. All right, next one is, we already did that. Can you tell us more about the neurogenic bladder, what it actually means?
So a neurogenic bladder is one where the bladder becomes somewhat flaccid and doesn't want to contract well. And this can happen in MS patients over time. It's just a bladder that doesn't contract because of floppy sac. And without that muscle tone to push the urine out, it just kind of sits there like a floppy sac. And we don't have anything that can improve that muscle tone very well. I mean, again, I've talked about the sacral nerve stimulation. That's about all we got. Once in a while, we'll use a medication called urocholine or bethanocol. It's an old-fashioned medicine. It doesn't work very well. It doesn't get absorbed very well, but it is out there, and we try once in a blue moon out of desperation to help the patient to void. But neurogenic bladder is a challenging part of our specialty.
Okay, do you see a lot of cases in MS patients with urinary retention? And how do you help them to deal with this issue? I mean, there's a lot of different questions. I'm just trying to tie them all in together here.
So, yeah, urinary retention is a major part of the MS population, the neurogenic bladder. We do, as I mentioned earlier, we do try to start off with self-intermittent catheterization. That's usually the first line treatment. If the patient can't do that for one reason or another, that they don't have the manual dexterity or it's too difficult or whatever, then we have to go to other alternatives. We did talk about the sacral nerve stimulation as being one alternative to help the patient's bladder to contract. We try to relieve whatever bladder outlet obstruction there is. If it means giving them tamsulosin or Flomax, I just mentioned a couple minutes ago, urocholine, bethanocol. It's supposed to make the bladder contract more. It just doesn't get absorbed very well, so we don't have that medicine used very often. And then as a last resort is an indwelling catheter. One that's in the urethra can do significant damage. It's hard to manage. And then the last resort is the suprapubic tube, where the catheter goes in below the belly button, directly in through the skin into the bladder, and the patient has that catheter changed once a month. Okay.
All right. Thank you for that. Now, here comes another trick question. Bladder urgency and incontinence are coupled with poor bowel control. What suggestions do you have for cardiovascular fitness? These issues impede my ability to do physical activity.
These issues impede their ability to do physical activity?
Bladder urgency and incontinence, coupled with poor bowel control. What suggestions do you have for the person to do cardiovascular fitness, because these conditions of his or hers impede the ability to do physical activity?
Yeah, I'm not clear as to how the physical activity. I mean, these are the issues that we've been talking about all night. So I think what applies to the other patients I've talked about, I think would apply to a patient trying to achieve physical fitness.
Okay. All right. Can you tell us about the Mannose Supplement?
Okay, that's interesting. So when patients have recurrent urinary tract infection, there's a number of anecdotal and folk medicine, traditional medicines that are used to try to prevent infection. So one of the ones that years ago was tried is D-mannose. It's a type of sugar that the E. coli bacteria will glom onto. And the theory is if they're being kind of stuffed with the D-mannose, they're less likely to stick to the bladder wall. And therefore, when the patient pees, the bacteria gets flushed out rather than sticking on the bladder wall. So the D-mannose is supposed to prevent the bacteria from sticking to the bladder wall. I haven't seen it work that well. My own personal regimen for prevention of urinary tract infection recurrence is to use methenamine hippurate, which we talked about. That's the antiseptic that's been around since the 1800s. And that works pretty good because it doesn't develop resistance. I also tell the patient to take vitamin C. Take 1,000 milligrams twice a day. You want the cheap vitamin C. You want the vitamin C that's not time release, not rose hips, not ester C, because you want the vitamin C, which is ascorbic acid, to get dumped in the urine. And ascorbic acid makes the urine acidic. The bacteria don't like acid urine. The other thing that I tell my patients to use is the cranberry pills, cranberry tablets or capsules. Cranberry juice doesn't work. There's not enough cranberry there. So you take a cranberry capsule or tablet, a pill twice a day with the vitamin C and the methenamine, and those patients rarely get significant infection.
Okay. Back to a Botox question. Can Botox cause urinary retention?
Yes.
Okay. Next question. Next question was, unless you had more to say about that.
Well, I mean, sometimes we do it on purpose. Sometimes it's better to have the patient in retention and dry, and they do intermittent catheterization. Like one patient was saying that they're getting the Botox 200 units and then they do self-intermittent catheterization 3 times a day. So sometimes it's done for that purpose. We generally say we try to use the Botox to calm the bladder down without putting the patient in retention, but it's a very, very difficult thing to do. You're trying to balance things out. Okay. So, yeah, it does cause retention sometimes.
Okay. I'm going to ask that nobody else put in any more questions because I would like to try to get through the remainder of what we have here. And I can't if everybody keeps asking questions, all right? I know you want to ask, but there's just a certain amount of time that we have, okay? All right. Gary has, what drug do you like to use for frequency?
So there's about a dozen medications out there for urinary frequency. There's basically 4 generations of bladder medicine. The first generation is oxybutynin, which is very strong and it works, but it has side effects, dry mouth, constipation, and can affect the cognitive abilities of an elderly patient. The second generation is Detrol and Sanctura or Trospium and Tolterodine. And these work pretty well, less dry mouth, less constipation than the first generation. Third generation is Toviaz, Vesicare, and Enablex. Some patients just like them. They're once-a-day pills, and they work pretty good, but they're still kind of drying. The last generation is Myrbetriq, which is the one that we talked about that can raise your blood pressure a tiny bit. Very little way of side effects. It's a beta agonist as opposed to an anticholinergic, so it's a different mechanism of action. Once in a while, I'll use something called imipramine. I don't know if any of your friends out there use imipramine, but again, it's an old-time medicine that we used in children who wet their beds. We can use a tiny dose, like 10 milligrams. It was originally designed to be an antidepressant, and for depression, you have to take 300 milligrams. So the difference in dosage is used. It does cause some dry mouth and constipation, but it has one benefit is that it tightens the sphincter, the urinary sphincter that can be kind of stuck in the open. It'll tighten it up a little bit.
Okay, thank you. All right, Rhonda wants to know if could bladder medications cause bloody noses?
Not that I know of, except they are drying. They do dry up, your mouth and your eyes, and they might dry up your nose too, and make you more prone towards epistasis, I guess.
Okay. Is Botox usually covered by medical insurance?
Yes.
Okay. How much water do you recommend on a daily basis to stay hydrated? Asked Carolyn.
Well, I'm going to give you the textbook answer. The textbook answer is 8 glasses of water a day. If I was drinking 8 glasses of water a day, I'd be peeing and drinking all day long, and I wouldn't get a chance to do anything else. But, in your population, I think it's very important for them to stay well hydrated to avoid complications with their kidneys, to avoid kidney stones. I think it's not a bad idea to stay. So I'll give you the textbook answer, 8 glasses a day.
Okay, thank you. Katerina wants to know, does estriol cream applied vaginally help with incontinence?
Yeah, I think it can. It helps plump up the tissues. It makes the bladder a little bit more stable. It makes those tissues just healthier. But it's not a cure-all. I mean, it's one piece of our armamentarium for the overactive bladder, and some patients respond better than others.
Okay, next one. MJ writes, with the suprapubic catheter, can a person swim with it in?
I do let patients swim if it's like clean water, like the pool. I'm always a little concerned about, let's say, going in the ocean or a lake, but they could take a plug. It's a catheter plug. It's sort of like just a cork that goes in the tube. They can roll the tube up and put it inside their bathing suit. And if they want to go for a swim, it shouldn't be a problem. I do recommend, though, after swimming to dry it off and empty the bladder, get any urine or water that's gotten inside, get it out. But I've had patients do this without any problems for a long time.
Okay, thank you. 2 questions remaining. Other than Kegels, are there any exercises to strengthen a female's bladder or sphincter muscles to have better control and less accidents?
Yes, those are the pelvic floor exercises. You can look them up online. The big problem is these are muscles that you're not used to using. It's very non-intuitive. So let me give you a hint as to how you could do this on your own to figure out how to identify the appropriate muscles. When you're urinating, start and stop the stream. And that'll teach you which muscles need to be exercised. But we don't want you to do this the rest of your life. The idea is not to complicate and make your urination abnormal, but initially you can use the urine flow to identify which muscles you need to exercise.
That sounds really cool. I mean, I haven't heard that before, but that sounds quite real. Quite real. All right. Last question is from Elise, and she says, does everyone using Botox need to self-cath?
No. The idea is to try to find that right balance to give them enough Botox so that they calm their bladder down, they can store urine, and when it's time to empty, they're still able to generate enough pressure to empty their bladder out. But it's a very difficult balancing act to find how much they need. We start off with 100 units, and then we go to 200 units, and in severe patients, we'll go 300 units.
Okay, thank you for that. So we come to the end of the night here, and, there's still a lot of people online. I'm glad that everybody's here. We did have quite a crowd tonight, and I want to thank you all for coming here. Of course, I want to thank the doctor as well. And, we have a tremendous amount of programs. MS Views and News is doing a lot. In fact, we're doing 10 programs this specific month of MS Awareness Month. And that's a lot. Okay. Obviously, it's quite a lot. So we, though, have normally we're doing 6 to 8 programs a month, which is still a lot. Okay. And, we want to thank our supporters for doing this. We want to thank all of our presenters for all these programs. And of course, we want to thank everybody that's here watching these events. So if you want to know what we do, instead of me going down the list, because there's too many to say, please visit our website, www.msvn, that's Mary, Sam, Victor, Nancy.org, and just go there and register for these programs. Now, once you're registered for a specific series, like MS NeuroTV, you're going to always be registered for that series unless we forget you have to start it all over again. All right. But otherwise, you'll always be there. So I want to thank Dr. Samowitz for being on tonight. I want to thank him for his time. And again, I want to thank you all. And, go with the flow. That's all I'm going to say is go with the flow. Okay. Go with the flow and do what you got to do. And enjoy the night as best you can. And stop drinking, all right? Because you don't want to be up all night, all right? So, yeah, okay. So, again, people are writing kudos, thanks, Doctor, marvelous, Dr. Samowitz. Oh, yeah, thanks, and Stuart as well. And big thank yous coming in from everybody on the screen right now. Not everybody, but mostly everybody. And I do want to thank you again. So you all have a great night. We'll be back very soon. Join us.
Be well.
Thank you.